I'm very glad that Professor Khademi for being here. Thanks to the Romano Psychiatry Center for taking care of this invitation. We have had an interesting workshop this morning focused on eating disorder, and which started with your presentation, interesting presentation. So we are truly interested in this change with psychoanalysts of other countries, and we consider this opportunity a very good opportunity for us. What to mention for the Italian psychoanalyst that Professor Khademi is an associate professor at the psychology department of Alliant International University, San Diego, where she is also the director of the Center of Applied Psychology, a counseling center designed to provide and evaluate evidence-based treatment. Mojgan Khademi is a clinical psychologist and psychoanalyst specializing in treatment of eating disorder. She's a member of San Diego Psychiatry Center and of the faculty at Tehran Psychoanalytic Institute, where she teaches and supervises mental health professional psychoanalytic training. So I would like to begin with a first question, asking you to tell us about psychoanalysis in Iran and about your commitment in sharing increasing knowledge of psychoanalysis in that country. It is the first question.
The psychoanalysis in Iran, and actually psychodynamic psychotherapy, but also psychoanalysis, really is quite blossoming. And I was not surprised because culturally there is a way that Iranian people are raised to think in terms of stories and meanings of stories, and I think it lends itself very nicely to psychoanalysis. The center that I'm associated with, the Tehran Analytic Institute, is in the process of becoming an IPA member, and they're starting to train their first group of psychoanalysts. Everyone has to complete a psychotherapy program first, where they learn sort of psychodynamic concepts and so forth. And then, so it's very exciting and different than other things that I do.
And there are difficulties in Iran for psychoanalytic thinking, I suppose.
Well, it's interesting because I would suppose that as well, but the challenges are interesting because there's so many inhibitions around talking about sexuality and many things, and also like I supervise a woman who was treating a man, and as a woman working, right, so she's covered up, she has a scarf and covered, and it was never, like, that's just sort of how it was done. And then this patient was actually going abroad and had requested they were going to do Skype sessions, and so he requested, since he was going to not see her at the office, basically, where they described, he said, well, maybe you don't have to be covered when I see you. And it created a transference, counter-transference situation where she was like, that it's a much more, even though like at her house, or like she didn't feel like she needed to be covered, but it's a requirement when she goes to work. She said, but it felt like a very, it was like undressing sort of in front of your patient, right? It's a much more familiar thing to be uncovered with the patient. So it was an interesting discussion of how to handle that therapeutically. What did it mean that he was asking for that? What did it mean if she was to do it or not do it?
And do you deal with every kind of mental health problems, or you can work only on some problems in a realm?
They work on everything.
Everything.
In fact, we are working on a book that will be about the various cases that she has, which I think are very different from what we see here in some ways. Actually, the issues are not different, but it's just like a very cultural, the cultural atmosphere makes such a difference in terms of how the problem is affecting someone. So it's neuroses and obsessions and fetishes and the case that I'm presenting at IPA is about a hysterical paralysis and mutism cases, so, which is probably like the most extreme of the cases that I've supervised them doing.
Do you think that there are some differences between mental health problems in Iran and mental problems Western society or USA? No.
No, it's interesting because I think they might be manifested differently initially. Where I do see differences are actually with personality disorders, for example. This was educational for me that I was supervising this psychologist who was treating this man who was, to my ears, was quite narcissistic, right? He was boasting and he was easily injured and he spent a lot of time talking about how great he was. And I thought, narcissist, like that wasn't that exciting to me. And it wasn't until I was talking to her, the director of the institute there, where I said, well, I know it seems like a pretty typical. And he's like, no, that's not typical. Like that presentation was not at all typical in terms of what they see, that it's usually much more hidden and people are not that sort of exhibitionistic in terms of narcissism. I was like, oh, sorry. It's like, to me, that was very normal. This is what narcissists look like, the overt narcissists.
So I appreciate very much your work. It's very important for IPA, for expansion of the psychoanalytic work. And so, the second question is about an intriguing paper work that you have for the next annual meeting of the International Psychoanalytic Association in Boston, I think at the end of July, yes, and you have a paper about the treatment of a case of hysterical paralysis. Can you give us some account, or you can share with us some thoughts about this topic?
Well, I can't give too much away, right? We want you to come to the conference and hear the paper. So this was a 21-year-old girl who was brought into treatment in a wheelchair, unable, and the only way she would communicate with the therapist was like the therapist would ask a question and she would, like with her eyes open and closing, she would answer like yes, no questions. And that was really the only part that was remarkable. The rest of her actual story was she had been jilted by a lover, and right, so it was like a very ordinary seeming story with this really extraordinary kind of a reaction. So we basically sort of tried to find different ways of reaching her and helping her really mentalize what had happened, what her experience had been that led to that, and interpret really the sort of the symptoms and how. I'll tell you one interesting part about it, that we, of course, I'm doing this on the phone with my supervisee, so I don't see, and of course I don't see the patient as the supervisor. But my supervisee kept talking about how nice this girl is and how sweet she is, and she's like a baby, and like she just wanted to take care of her, and but the story, including all of sort of her behaviors that went against the cultural norms, which led to what had happened with her lover happening, etc. But I was like, she can't be that innocent, you know? She has this whole past that we sort of know about from other people, but she's not speaking, so she's not telling us. And so, like, we really had this, the countertransference of, like, this baby that needs to be taken care of was really getting in the way of doing the work. So we asked her, the therapist asked her to bring some pictures of before the paralysis and what had happened. And it really, it was almost, it was like a way of reminding her and the therapist that she was this independent, wild, by Iranian standards, you know, girl who sort of got herself in trouble by actions and then couldn't deal with the consequences, basically. And to really, for the therapist to be able to step away from that and do that. And she started to talk, and we wrote the paper in order for it to be submitted. We only had like 10 weeks, I think. So by the 10th week, she was walking and talking, and right, which was remarkable given sort of the state that she was in and where she was at the end. Because I was writing it up, I think the therapist felt some pressure, like, I must get her better. And I was like, you don't have to. This is interesting, whether this works or not. You know, we don't really see that in this culture. And so that's sort of what the paper is about.
Yes. Now a huge question. IPA is deeply interested in debate and possible collaboration between research and clinical work, psychoanalysis, and as well as for the commitment of the psychoanalysis in teaching in university. And so it's very important for psychoanalysis and for the psychoanalytic movement. So I would like to ask you some account about your work at the Alliant University, because you have a work as a clinical psychoanalyst and as a researcher. So I think that it could be very interesting for us to have an idea of how you can deal with the two different branches or areas of psychoanalysis.
I think the biggest challenge is time. Really,
yes, it's a challenge.
To be able to devote to, because I love my clinical work and I can do that day in and day out. What's been interesting is my research always has an attachment component to it. So students who want to work with me know that in one way or another they're going to be looking at attachment of whatever the topic is that they've come in with. But it's helpful to have people to collaborate with and work with. So, for example, I have a student who is from Iran who is wanting to do a dissertation. She has an interest in women immigrants' well-being and relationships, something very vague. So, of course, we have to make that into something that's studyable, and I used to have a lot of help from Gaia with them in terms of putting them together. What we realized was that we could use one of the psychologists that I work with in Iran to collect data in terms of attachment and relationship satisfaction of Iranian women who never immigrated, and then compare them with those who have immigrated, you know, with immigration being such a rupture, right, in terms of their experience. So it's been nice to have, I've had to be creative in finding lots of help and people helping me sort of making the research happen. The other part has been having sort of consistent idea. For example, with eating disorders, this idea of a psychodynamic approach to prevention of eating disorders. So it's been a series of studies. So it's like I don't have to think a lot. I just thought once, and then it has sort of given birth to several studies that, right, so we looked at whether there was a relationship between mentalization, security, attachment security, and eating disorder risk. And so the next step was, we're actually sort of looking at the same thing with adolescent boys right now to see whether there's some similarities with boys, if these issues are relevant for boys, and then an intervention looking at whether we can improve mentalization as a way of addressing eating disorder risk for girls, and then comparing it. Really, I'm not interested in comparing it, but I'd like all of the more cognitive behavioral approaches to incorporate mentalization into the I don't want to compete with them. I just want them to acknowledge it and have it be incorporated into that. So these projects sort of, because they have like they build on each other, sort of, I can do them easily then.
And I wonder if you sometimes has a kind of crisis of identity. I mean that when you're in the mental state of psychoanalysis in a session, it is different. When we are a psychoanalyst, but we have to follow figure, experiment, and so there is a connection, of course, but it's not the same. So I mean, if you're sometimes there is an imbalance or the crisis or difficulties to take to get these two different attitudes.
So I think my experience of immigration actually has helped me be able to negotiate two different cultures and be able to sort of have a balance. So it probably helps me with, as I traverse other worlds that don't necessarily go together. So personally, that's what I think helps, and I think that I think when people understand psychoanalytic concepts, if I can explain them to them in a way that's understandable to them, I think people are more open to it, and then translating it into something that's researchable kind of makes sense. So I don't feel like I have to force it. But sometimes I feel like, among the psychoanalysts, I stand out because I do this weird research things, and among the researchers, I stand out because I'm a clinician, and as soon as they ask a difficult statistics question, I have to ask Gaia to help me explain what it is that they're talking about. So, but yeah, it's hard. It's a challenge.
Many thanks. Another question is the problem of evidence-based perspective that you can find, of course, easily in behavior therapy or cognitive behavior therapy, but it could be more difficult for psychoanalytic treatment. What do you think about the possibility to have evidence-based in psychoanalysis, and what kind of treatment programs do you follow with this goal?
Well, I think that I'm at once I am for and against empirical supported treatments at the same time. People like Thompson Brenner and Weston, for example, I follow them because they critically look at what is wrong with the research that's being done, the randomized controlled trials, etc., and the assumptions that are implicit in how they do these studies, because they really sort of make you question, right? So you can't just say, sort of like I was talking about this morning, you can say, oh, cognitive behavioral therapy is a treatment of choice because that's empirically supported, but when you look closer at it, it's like, well, okay, but there are all of these issues because of the assumptions that they do. For example, they want to create as homogeneous a sample as possible for their studies, so they exclude all kinds of people that we see in treatment, or the idea that because it's an experimental design, you want it to happen within a short period of time, because the longer it goes on, the more you can say, well, anything could have made this change, right? So I think it's important to think about that and be sort of critical of the findings in terms of what's empirically supported. At the same time, when I teach, it's helpful to kind of to have some kind of a guideline or guidance in terms of these are some of the things that they have found helpful. And really the challenge when I teach is because I think students really like that, oh, okay, I do this, it's very simple. And really the challenge is saying, no, that's not, this is where you start, so you know that this works, but you have to sort of really look at all of the data, and you have to do more than that. Like to teach them to think. My husband's a physician, and we often talk about the problem with medical students also, who similarly as medicine has moved towards this empirically based, so they're no longer teaching doctors to think, they're just learning if this, then that. And it makes my husband crazy because he's like, no, think about it, think about why this is, and so forth. So
a second huge question is about the importance of using an integrated approach. You highlighted this point very much in your paper, and I think that's a very important matter of discussion, because when we have to deal with eating disorders, it's necessary to have a combined strategy and to collect and to organize different layers of intervention. Can you give some accounts about, in general, about your method about an integrated approach?
I think the challenge whenever I talk about an integrative approach is that I don't want to water down the important parts of what I'm doing, and especially the psychodynamic part. But it's challenging because I think I like everybody to get along and work together. It's hard when I teach with people who are very CBT, and they sort of very rigidly do this, and so they don't like it that I incorporate that into this other thing that I do. But actually, I know that CBT started out that way, right, with psychodynamically trained people saying, hey, we like to do more stuff. So actually, right, so I feel like integration should be more the norm as opposed to the exception. Really, people are complex, right? There's all kinds of things that goes on with them. There's fantasy, there's thought, there's feelings. I think the more that we can sort of bring together the various approaches and use them, I think the more successful it can be.
Two sub-questions for the integrated approach. The first is why you have the focus on the interpersonal factors, why they are so important for patients with eating disorders. It's the first sub-question. The second one is more technical. It's about the possibility and how much is possible to use transfer and countertransference in your work with this kind of patient, and inside the lens of the work that is different of the classical psychoanalysis.
In terms of the first question, I think the interpersonal issues relate to their attachment difficulties. So eating disorder patients tend to be, in various studies, they score as someone who really needs relationships and wants connection, but at once also avoids and rejects and keeps away. I think that makes them vulnerable in terms of societal expectations of if I look like this, then I get loved, then I'm wanted, etc. I think it makes them more vulnerable to that, which is I think what we see. But as I talked about in this morning, it's so difficult for them to trust that it's okay for them to be genuine and authentic and who they are, and that to be accepted as such. I think that gets into. I'm not sure if I answered the question about transfer. I think you have to. I think that without addressing what's happening in the room and without paying attention to my own reactions to them, I don't always maybe address the transference countertrends, but I certainly try to always be aware of it, because I think it's enacted if you don't pay attention to it. But what I've also found is that, like I said, with eating disorder patients especially, they really appreciate honesty, like being honest and saying, this is what I see. What do you think about that? Without me really imposing a big interpretation on it, because oftentimes, I feel like we don't know what goes on inside of these women's minds or their fantasies. And sometimes really I feel like I really think I don't understand what's going on, right? It's not like, oh, I know, I'm just like waiting to tell you what it is. And even like I had this anorexic patient who was, she kept talking about wanting this particular Starbucks drink. But she kept talking about it. And finally I was like, well, just have one. Like, I don't understand why, bless you. I don't understand why, because I was frustrated. So anyway, so I said, so what would be the worst thing that would happen if you had this drink? And she says, oh, it's not that. It's that if I have one, then I'm gonna want to have one every day. And I thought, oh, I now understand. This is that fantasy, right? I'm insatiable. I will be out of control. I'm one Starbucks latte away being completely, chaotic and out of control. And so like that fantasy helped me understand. So then when I could say that to her, and then I noticed how in our relationship she was similarly very regimented in terms of what we talked about and when we met and so forth, right? Then I could sort of relate that to our relationship. So I think I do it because it works. I think it's been reinforced that you can do it. And it's different than when I'm interpreting the transference in psychoanalysis, which is much more, I think, in depth in terms of what's happening in the relationship. But I think you can do it much more on the surface in terms of the immediacy of the relationship and still have it be effective.
Okay. Many thanks indeed for your contribution. So we're really glad the possibility to have this link with psychoanalysis and another world.
That's right.
For you is of course the same, I suppose.
Absolutely.
It's important to have the possibility to compare differences and to find points of meeting.
Absolutely.
Absolutely.
This is great. Yeah.
Many thanks.